Good evening, everyone. Welcome to the DCR Journal Club. Hello to anyone who may be listening on the YouTube channel on the recording. This evening, we are fortunate to return to Baylor University Medical Center in Dallas, Texas. This team has hosted the Journal Club about 18 months ago now, and we had an excellent session there. So it's fantastic to be back, and thank you again for making the time to support this project. This is our team. This is our disclaimer. As is my custom, an interesting fact about Dallas. So I found that the first 7-Eleven was founded in Dallas back in 1927. I thought it was an Asian chain of shops. There you go. So now I'm indebted to Dr. Katrina Wells for being the contact person for this session. She's incredibly prompt at answering all my emails, which is quite unique. So I will ask her to briefly talk about her city, her team, and her institution. And further, after we have the discussion, I will direct my questions to Dr. Wells, and then you can quarantine and distribute them as you see fit amongst your colleagues. So again, thank you very much for making the effort to host us.
Thanks, Dr. Bolshinsky. Thanks again for hosting us. We are very honored to be able to participate again. We're very proud to be highlighting Dallas and Baylor University Medical Center in Dallas. As many of you know, Dallas, it's a huge metroplex, ever growing, especially in the post-COVID state. We've had a real influx of population and growing north and south and east and west on top of one another. So there's no shortage of patients. There's no shortage of experiences here. It feels like everything you could possibly want happens to be in Dallas, except for the beach. We have a place in history in 1963 with the assassination of President Kennedy when he came to visit. We've definitely turned around in reputation since then, and we are a major corporate hub for many of our countries, Fortune 500 companies. It seems to be ever growing still, including 7-Eleven, which is still here in Dallas, and American Airlines, Exxon, AT&T, et cetera. And it's so nice to be able to enjoy, since COVID, our one of the largest arts district in the country. We have multiple museums. It's really just a bustling metroplex with, again, exploding numbers of restaurants, music venues, sporting events, and public entertainment. So we really hope that after this, you may want to be motivated to visit Dallas, even you, Dr. Bolshinsky. As you know, there's a direct flight. So we are at Baylor University Medical Center in Dallas, which is the flagship of a major system called Baylor Scott and White, which consists of multiple hospitals across the metroplex and North and Central Texas. Being the flagship, we are a tertiary care center. We're a huge catchment for advanced disease, and we are nationally recognized with U.S. World and News Report, highly ranked in the areas of GI and GI surgery, which we're very proud to be a part of. Our colorectal surgery division consists of 9 colorectal surgeons. We are chaired by Dr. Fleshman, and we educate 3 fellows a year. So we're one of the larger, and we are the second oldest training program in the country. We have, as a faculty, a very strong commitment to the tradition of the program and to the education of the fellows. They are really our shining star within the hospital. So we're very excited to introduce 2 of our 3 fellows to you today, who will be presenting the papers.
Hey, I would just add that 7-Eleven got started selling ice. But while they were selling ice, they said, you know, maybe we could sell eggs and bread and a couple other things in addition to ice. You know, Dallas would not be around were it not for ice and now air conditioning. Anyway, the rest is history. So ice became secondary to selling everything else.
I guess now you sell Teslas.
Yes, and everything else.
Dallas is the home for all Chevrolet Suburbans, Tahoes, and all the big. It's a huge assembly plant in Arlington. Yeah, at one point, 50% of the Suburbans in the country were in Texas and sold in Texas.
So we're going to be presenting two papers today, the first of which will be presented by our colorectal fellow, Dr. Christian Sommerhalder. And our discussant will be our faculty, Dr. Sarah Stringfield. The second paper is going to be presented by our second fellow, Dr. Carla Newton, and I will be the discussant for the second paper. We are really lucky to have, as you can see, a treasure trove of wisdom and history, Dr. Lee Schleider, who is our panelist, and our special guest, Dr. Ficara.
Fantastic. Thank you very much for that. So we have a poll, and the question for the poll is related to anticoagulation. So in a patient with AF, on what postoperative day following an ultra-low anterior resection are you prepared to recommence therapeutic anticoagulation? This is something therapeutic anticoagulation I personally grapple with often. Literally earlier this morning, I just reversed a loop ileostomy on someone with factor V Leiden, and I get told, restart as soon as possible. And I always worry what that actually means in terms of balancing things. This question particularly is related to a paper that we featured from the spiritual home of colorectal surgery, being Australia, where Dr. Christopher Young was the senior author. The paper is called Complications Arising from Perioperative Anticoagulant / Antiplatelet Therapy in Major Colorectal and Abdominal Wall Surgery. It's featured on the DCR website this month. So whilst people are answering, let's start the discussion for the first paper. So as Dr. Wells kindly mentioned, it's going to be discussed by Dr. Sommerhalder and Dr. Stringfield. So thank you very much for you both. The paper is titled Risk of Postoperative Venous Thromboembolism After Surgery for Colorectal Malignancy, a Systematic Review and Meta-Analysis. And we're also very fortunate to have one of the authors, Dr. Lewis Lloyd, from the UK, where it is after midnight now, on the call, and would be grateful if he also makes some comments. Thank you. Let's start.
Yeah, thank you for allowing me to present, and thanks for Dr. Lloyd for being here. I know this was quite a very large undertaking. So quickly through the background here, they go over a broad overview of colorectal cancer. So stating that it is the second highest mortality of all malignant disease, about 1.8 million deaths per year. For colorectal operations, they are known to be some of the highest risk abdominal operations regarding venous thromboembolism, with malignancy being even higher, almost 2 to 4 times higher than benign operations. And then they go through a previous Cochrane review that had similar topic of this paper, in that VTE rates were about 117 per 1,000 person years, and similar minor bleeding rates to the VTE incidence, with about half the incidence of major bleeding in that previous paper. And then it goes through kind of some of the more recent changes. As we all know, ERAS programs, minimally invasive focus in colorectal operations, and how this may change the venous thromboembolism landscape and hopefully reduce the incidence of such. And then lastly, they mentioned one single previous study which showed no difference between open and laparoscopic cases, but that study had several flaws based on the timeline and how it went through, maybe just looking at DVT, maybe just looking at pulmonary embolism. And so they wanted to kind of focus on this and reassess the incidence in the newer landscape here, and through all studies through a meta-analysis. So per usual, the PRISMA and MOOSE guidelines were followed for the systematic review and meta-analysis respectively. They went through basically every database possible, including gray literature, so Medline, Embase, Cochrane, clinical trials as well, basically from the inception of each database to August 2019 is my understanding. And again, use Google Scholar to look at any gray data or gray papers that may not have been in one of these databases. Basically, the most encompassing search that you can do. They use no geographic or language barriers either, so this was a worldwide study. For exclusion criteria in general, they were looking at adult patients. So any cohort less than 18 years of age were excluded, or cohorts with benign disease. So again, looking at colorectal malignancy here. And then also excluding completely endoscopic procedures. So these were operative intervention, surgically operative intervention for colorectal malignancies. And then studies were also excluded if they only were looking at DVT or PE and not both. So the primary outcomes for the paper were 30 and 90-day incident rates for venous thromboembolism per 1,000 person years here, the results. So in the end, they started with 6,441 papers. And so 52 met their inclusion criteria, and in the end, 28 studies were used for analysis in the time range of 1987 to 2017. So they subdivided this into several groups, and the first of which was an overall overview of the incidence or pooled incidence of venous thromboembolism. And so overall, it was 1.9% at 30 days, or 195 per 1,000 person years at 1 month or 30 days. And then at 91 per 1,000 person years, or 2.43 incidents at 3 months. And then they separate it further into geographical or geo schemes, and looking at different countries and how the incidence of venous thromboembolism varied from country to country or region for region. And so the Americas, which had 6 studies, actually had the highest incidence, almost 4 times the European incidence and almost double the Asian incidence, so 284 per 1,000 person years, whereas Europe had 71, Asia had 176 at 1 month. The number of studies varied a little bit looking at a separate time point. So the 3-month time point now, we had 5 American studies and 1 European and 1 Australian study. Again, the American studies demonstrated just over double the incidence of venous thromboembolism compared to European and Australian trials. The next step was dividing colon versus rectal cancer. So the colon cancer incidence initially at the 30-day mark was a little bit lower than the rectal cancer incidence at 1 month. And so but this changed at the 3-month mark, where the rectal cancer was a little bit higher than the colon cancer, is my understanding. So 2.7 for colon and 1.7 for the rectal cancer at 3 months. Lastly, similar to the previous paper mentioned in the background, they looked at laparoscopic versus open, which they did not find. My understanding is they did not find significant difference between the two, but if you look at their numbers, 3.1 compared to 2.6, there is a difference, but maybe not significantly different. And then through all this data, and this is somewhat expected for this type of trial, but the heterogeneity, the trials were very heterogeneous. So the I-squareds and the vast majority of these are over 90%. And so again, you're looking at very large trials, number one, and you're looking at different geography and different kind of outcomes. And so that was somewhat expected here, but just as a note. You can go to the next slide, thank you. So the conclusions here, the reported venous thromboembolic incidence in this trial was slightly higher than previously, and it was higher as expected than benign operations have been. The Americas, or mostly North America, where these trials came from, had significantly higher incidence than Europe, Asia, and Australia, either at the 30-day or 90-day mark. And they came in to question why this may be. For example, obesity incidence is higher in North America as compared to some of these other countries. Maybe the surveillance techniques or habits are a little more thorough or a little more frequent than the other countries. But with the size of this analysis, it was difficult to kind of tease that out. And then with a kind of a different payer system or a private insurance system, you know, the compliance of following with prophylaxis may be different in America versus other countries where they have the socialized healthcare system. So as kind of discussed, high study heterogeneity, not necessarily a weakness, but maybe inherent to the study itself. And then again, the inability to maybe tease out, you know, why the VTE incidence was a little bit different in each country, or the finer details when you have kind of a broad overview like this. And then lastly, they conclude that extended VTE prophylaxis may help decrease incidence. And then there's even a question of, should we go from just a 30-day coverage, which may be a little more common, to a 90-day coverage due to the continued incidence at 3 months following operative intervention. And they again found that there was no significant difference between open and laparoscopic operations in this study. So that's a quick and dirty of the study there.
Thank you very much for that. And now, if I can get Dr. Stringfield to just give us a couple of her salient points, please.
Yeah, so thank you, Dr. Sommerhalder, for that good summary of that article. As he said, it's a systematic review and a meta-analysis. So congratulations to the authors who's on the call, of course, for all the time you spent combing through all of the thousands of articles that met your initial search criteria. Because VTE is a topic that's long been studied and published on. And so a reason for the numerous publications and for this publication, however, is because the medical community hasn't really been able to clearly establish the risk of VTE after different surgeries and in different patient populations. So we know that abdominal operations put patients at risk for VTE, and malignancy increases that. Therefore, colon cancer surgery is one of the highest risk operations. But exactly how high is that risk? And of course, that's what the study was trying to look at. It used 18 studies, and there was over 500,000 patients. So obviously a very large number of people were included. That's one of the benefits of doing a meta-analysis, because you can have such huge numbers of patients that you wouldn't be able to get with single studies or databases always. These results help define the incidence and the rates of VTE after colon and rectal cancer resections. And the numbers aren't really surprising, but it's important to establish these numbers. And as Dr. Sommerhalder commented on, some of the downsides of meta-analyses and systematic reviews is that there's very little detail on information regarding these patients. So all of the studies that were pooled were performed differently. They had different patient populations. Pooling all of them together limits on what you can learn from such a big study like this. So we don't know what percentage of the patients got prophylaxis, screening for DVTs, how long they were in the hospital. We don't have any of their risk factors like age or use of neoadjuvant therapy. We just have the information of the group as a whole. So without this more salient information, it's hard to know the major reasons for differences in the groups, which they tried to break this population into. So the authors broke the group down into a couple smaller groups, one of which was geographic regions. So I think one of the goals of the study, which they can correct me on, it was to get information kind of on global rates of VTE in the colorectal cancer population. However, when you look at where the studies came from, 17 of the 18 studies are from countries that are predominantly Caucasian. So the only exception was South Korea, which may be a limitation of the study, and you do see differences in rates according to regions. So I don't think you could necessarily apply the rates that were found in the study to more of a global population and other regions and ethnic groups. So why do we care what these rates are? Well, because these outcomes are preventable and potentially deadly when they do happen. And prophylaxis doesn't come with any downsides. The rates are low as they establish, but they're not zero. So some of the questions I would propose maybe to the other panelists is a study like this looking at overall rates in a big group of patients really helpful to our practices? Do we need more studies like this, or using the information that they were able to get in this study, should we continue to give prophylaxis to everybody, or maybe just be focusing more on subgroup analyses in order to see which patients are at the high risk and only giving these patients prophylaxis? But overall, I thought it was a great study, and I'd love to hear input from the authors. Thank you.
Thank you very much for that. Yeah, very interesting questions you raise. If I could possibly get the Dr. Lewis Lloyd on to comment, and to add, I'd like to say, just quoting what they wrote, within population-based cohorts, it was not possible to separate symptomatic VTE and incidental VTE diagnosed on screening. Now, I wonder also if the authors have come across any studies that performed prospective Doppler ultrasounds to actually see what is the incidence of VTE in the asymptomatic sort of patients. And the other question I have, although I don't want to heap so many questions on, is having completed a meta-analysis, what would be your advice to someone who is keen to run a randomized controlled trial in this topic in the colorectal space?
So first of all, thank you for having me on, and thank you for presenting our paper. So to the first question, is coming across papers that have done pre-screening of for VTE. There's been a few, but when it comes to the national population-based databases, you don't necessarily see that at all, because these are coming from large, or it's routinely collected data from things like, well, in the UK you've got HES, and America you've got your ACSN script and factors like that. So I've seen a few, but they're mainly in the randomized control trial populations, and that's where unfortunately we couldn't really pop those into the paper, as when we looked at the follow-up lengths and the way they were screening and looking at patients, there was a massive difference in the VT outcomes. So some were only looking at symptomatic, others were looking at asymptomatic and following them up at different days. So you go from 0 to about 15% people having a VTE. It just wasn't really feasible, or any tangible information that we found. And I would say, going forward, probably with VTE, because albeit a relatively rare complication, only about 1 to 2% or up to sometimes 4% in symptomatic, in 30-day symptomatic people, you're going to need large numbers. So I think probably using large databases and specifically targeting, so different groups are looking at, I know, people, elderly, those who have undergone neoadjuvant chemotherapy, are the ones that have risk factors. And looking at, so to your second question, with a randomized control trial, I think it's actually something I'm looking at trying to do now in my academic work. So moving on from meta-analysis and cohort studies, but I think it's looking back at what people have done in the past. So for example, there's the Vedovetti trial that was looking at laparoscopic colorectal cancer surgery and VTE. And looking at how they've set up trials, and particularly moving from a pilot trial to an RCT. So powering the study is going to be quite difficult. So it would be a multi-center type thing, and starting off with actually looking at screening patients at 7 or 28 days and seeing if there is a difference. For example, if you're looking at, I think the next thing would be to look at patients undergoing benign colorectal resections. So we all talk about extended prophylaxis for cancer patients, and that's in the NICE and ACCP guidance, but we haven't really got strong evidence looking at benign colorectal resections, particularly in the IBD population. It'd be interesting to know what other people's thoughts are on extended prophylaxis or or more rigorous treatment of patients having inflammatory bowel disease resections.
Thank you. Yeah, so the next paper we have is on IBD, so it'll be great to compare the two. Just taking up on the sort of colorectal cancer patients and DVTs, a brief Google search for me showed that or at least the quoted risk of annual DVT-PE in colorectal patients treated with chemotherapy is about 10%, which is interestingly far greater than the incidence of DVTs in the 3 months post surgery, which is in the meta-analysis quoted as 2.43%. So I think there's a lot of gray in sort of identifying which patients are likely to get DVTs and not. Dr. Fleischman, I think, wants to say something.
So what I'm asking is, we've gone back and we've looked at large studies and reports, but we have ongoing national registries. I know the NHS has one. The American College of Surgeons has the National Surgical Quality Improvement Program. I'm wondering if we could start using those to help us with that, rather than going back and recreating a randomized trial, just to see if we really made a difference and how we're doing with current therapy.
I would fully support that. So I think that is probably one of the ways to go. Looking at large population-based data is because you're able to not only look at different specific subgroups of interest, you've got a large amount of data and you're able to see maybe small nuanced differences that actually might make a difference in clinical practice. Thank you.
Two more comments, I think, from the faculty. So Dr. Fitzgerald and there was someone else. I can't quite see who it is. Maybe Maggie can help. Yeah. Oh, yeah. That's Dr. Fitzgerald there.
Yeah. I think Dr. Lee Schleider raised his hand first. But my question will be fast. I would argue with Dr. Fleischman that a prospective randomized trial will give us an opportunity to actually screen and check on these patients. The problem with these studies is if we wait for clinical evidence, we are missing, in my opinion, a lot of them. A well-designed randomized trial when that's like was said earlier, 7 days or 28 days or whenever you decide, people get a Doppler or whatever imaging modality you seem appropriate, I think will tell us a lot. And my second comment is, we are focusing on disease specific, cancer, rectal, colon, IBD. But as Dr. Stringfield alluded to, we should focus on the patients at risk and reframe the question rather than, a 35-year-old with a right colon cancer, you do a robotic right hemicolectomy with intracorporeal anastomosis, a very different story that a morbidly obese smoker with low rectal cancer. So I think we should focus more on risk factors for DVT, like Dr. Stringfield was sort of alluding to.
Yeah, just a couple comments. When you look at a lot of work done on this, you still come away quoting a 1 to 2% risk of DVT and/or PE, which is kind of out there prevalent. Even the ABSITE exam for general surgery residents, the correct answer in the ABSITE is DVT prophylaxis after 30 days after colon cancer surgery. So there's enough acceptance for some of the things that this article points out. I would mention this was from 87 to 2017, which predates, for instance, Lovenox was not released until 1993, and most ERAS protocols were not up and running with ambulation, et cetera, et cetera. Probably the biggest question I have, and it's not been addressed, is compliance with sub-Q injection, cost, approval of insurance, And is there a way, if you're going to do a randomized trial, it'd sure be nice to look at low dose oral DOACs or oral anticoagulants, Eliquis, Xarelto, would the complication be less, would the efficacy be as equal, and would be far greater compliance for a patient to take a pill than the injection. So it's not been done, but it sure would be interesting to look at that. And Dr. Stringfield's point, risk factors relative to obesity, race, ethnic, insurance status, socioeconomic status. Clearly there's people at various risks, and we don't know the answer to that.
Thank you. My biggest question, and we'll move on after this, is I'm not sure we understand the timing of DVT and PE. So does it occur on the table during surgical intervention and then may manifest following a delay? Or can it be occur due to a delay of surgery due to multifactorial issues, whether it's, perioperative complications, whether it's sepsis or something that produces a pro-inflammatory state? And if it is something that occurs on table initially, should we focus more on ensuring that we have uniform DVT prophylaxis for patients whilst they've been operated on? Because certainly where I work, most people say that they're proactive in anticoagulating patients whilst they're operating, but there's actually quite significant differences in terms of, do they get it on induction? Do they get it 6 hours post? Do they get it, the next day? And I'm yet to see that explored in studies in terms of the perioperative uniform protection. If there's no other comments from the chat, perhaps we'll move on to the next paper. The title of the next paper is Venous Thromboembolism in Patients Admitted for IBD, an enterprise-wide experience of 86,000 hospital encounters. It's a paper from the Cleveland Clinic. I believe Dr. Hollebar was the senior author for this. This paper will be presented by Dr. Newton and then extra comments by Dr. Wells. Please start when you're ready. Thank you.
Okay. Well, thank you again for having us and letting us participate in this. So I'll just go ahead and get started on the next slide. Just as a general brief background, IBD patients are known to have an increased risk of venous thromboembolism and pulmonary embolism. However, in general, there remains a pretty wide variety in practice patterns and a relative lack of national guidelines. This was a retrospective review which queried the EMR system for adult patients with ulcerative colitis or Crohn's disease who had an inpatient hospital admission within the Cleveland Clinic Foundation between January 1st, 2002 and January 1st, 2020. They collected a wide variety of data, including patient demographics, disease-specific characteristics, hypercoagulable disorders that were already present, if surgery was performed, and if VTE prophylaxis was given. And the primary endpoints were overall 90-day rates of DVT and PE separated by time of diagnosis during or after admission. So over 16,000 adult patients with IBD had over 86,000 admissions during the study period. Only 50.2% of these patients received VTE prophylaxis in the hospital. The 90-day rate of DVT and PE was 4.3 and 2.4% respectively, with 53% of these actually occurring post-discharge. A multivariate analysis was also performed and identified risk factors for both the DVT and PE, which were overall pretty similar and unsurprisingly included lack of VTE prophylaxis. Interestingly, the cumulative risk and rates of DVT and PE were higher in patients admitted to medical services when compared to surgical services, which is demonstrated by the figure on the slide. And more surgical patients were on VTE prophylaxis while in the hospital, and surgery was not identified as a risk factor for developing PE or DVT. So overall, VTE prophylaxis administered during the hospital was protective of DVT and PE events in both medical and surgical cohorts, which overall makes sense. It was a little surprising to me that patients on a medical service were at higher risk for VTE, and over 50% of the events occurred after hospital discharge. I've just kind of looked it up in general, kind of maybe how the hospitalist would be approaching this, and there are several prediction scores for hospitalized patients, and if VTE prophylaxis is indicated, none of them specifically mention IBD or risk or address VTE prophylaxis after discharge. There are some limitations of this study, mostly pertaining to its retrospective nature and inability to validate clinical severity scores. Use of compression devices was also not captured, and the use of diagnostic codes may have missed subclinical VTE events. I think what the study has demonstrated is there is a need for more aggressive recommendations regarding VTE prophylaxis in IBD patients admitted to medical and surgical services, as well as consideration of further study into post-discharge extended VTE chemoprophylaxis as well.
Thank you very much for this succinct summary. Now, can I get the microphone to Dr. Wells, please?
Thanks, Dr. Newton. That was a really nice summary. I enjoyed reading this paper. I think it's a fantastic effort from clearly a very high volume, well-known center that managed to capture 86,000 encounters with hospital level data, which, if you've ever tried to do that, is very challenging because it's hard to account for a patient traveling through those many years, 18 years, and capturing incidents of disease and making sure that there's not confounders, making sure that there's not repeat admissions for same patients. So it's a huge undertaking, and it's credited with being in a single center because, just like the issues that we discussed on the previous paper, when you're looking at something that has a very low incidence, you have to look at a massive number of patients, either pooled through multi-center trials or through meta-analyses like the previous study. And as you get farther and farther away from the data, the details, you lose some of the details that answer the question you initially wanted to answer. And clearly we know that with DVT prophylaxis, all of the questions that were raised: when to deliver it, when does it occur, what are highest risk factors? The devil is in the details. So it's a massive undertaking, many patients. And I think they highlight, as Dr. Newton mentioned, two very important takeaways. One, the risk of DVT is high in the IBD population and prolonged. So it's not that 30-day admission that we all worry about. It's beyond 290 days. The other important takeaway is that the medical patient, of course, we're all surgeons, so we're focused on the surgical patient, but that the medical patient carries the highest risk, at least in this comparison. And so we really need to focus on guidelines for prophylaxing those patients. And we only recently have from ASCRS practice guidelines for how to consider prophylaxis in our surgical patients. So it recognizes a very large unmet need. There are some limitations to this study. One of the problems, or one of the limitations, I'll say, is, as Dr. Lee Schleider raised in the previous paper, this is an 18-year experience where many changes in how we manage our surgical and medical patients, many changes in how we treat IBD, even many changes in the landscape of the severity of disease. And what I mean to say by that is we are treating patients medically to a severe state before they come to surgery now. I think even my short experience, in people with longer careers will agree that when they come to surgery, we're seeing much sicker patients. And so the medical patients are probably over this 20 years physiologically much worse off than they were 20 years ago. We have implemented ERAS more effectively over 20 years, including early ambulation and prophylaxis chemical prophylaxis strategy. And one of the other issues in this paper is, as I mentioned, looking at hospital data. We are missing some of the details about how prophylaxis is administered. And again, we have some unmeasured severity of the disease of the patients in comparing medical patients that are hospitalized for the purpose of IBD. So assuming these are patients with acute flares or bleeding, which would prevent them from getting chemical prophylaxis, compared to surgical patients who, for the most part, come for semi-elective or elective procedures where hopefully we've managed to optimize to some degree the acute IBD state. Not always the case, but we don't readily sign people up for patients in flares unless our hands are really forced. So there's not a great comparison between the medical patient and the surgical patient to say that one is perhaps worse than the other, but the takeaway is that it's high. There are a couple other things that I think are worth mentioning in the analysis. One, that inpatient prophylaxis, and I think there was a little bit of a typo in this paper, unless the authors are able to correct my misunderstanding. But one of the takeaways also, and a little more of a subtle point in this paper, was that inpatient prophylaxis, even when administered, whether Lovenox or unfractionated heparin, was not protective for risk outside of their admission. So, and I think it's mentioned in the supplemental tables, but there's no significant difference between patients who received prophylaxis in hospital versus who didn't, who then went on to develop DVT at 60 and 90 days, emphasizing the need that patients do need to continue on extended prophylaxis if they're considered high risk. How do we consider high risk? They didn't really explain how patients were chosen to receive low molecular weight heparin or Lovenox or not, including whether or not there were any contraindications to providing that prophylaxis. But looking back at our clinical practice guidelines, you can kind of get a hint that probably many of these patients would meet scoring criteria that we have in our guideline recommendations, like Rogers scoring and Caprini scoring. So you can assume that probably it wasn't really a calculated risk to not give prophylaxis or give it. It probably hints to just a lack of education or lack of adherence to known guidelines. So I would like to say for comparison, the surgical group, it's a little hard to glean. I mean, I would like to pat ourselves on the back. It almost seems like having surgery, though the authors say there's not a risk associated with surgery, it almost seems like there's a benefit, and I'd like to give ourselves a little pat on the back for that. It probably just means that we're probably more, like I said, optimizing our patients. We're probably more aware of the risks risks surrounding an operation rather than a patient coming in the throes of a medical crisis. And so we were more adherent with DVT prophylaxis. But at the same time, if you look at the large group of patients, we're really only 14% of it. So I think it is hard to, it really is a comparison of apples to oranges, though it worked out in surgery's favor.
Thank you. I actually think that we need to give the pat on the back to the nurses and the physios. I think that's the biggest difference between a surgical ward and a medical ward, that patients are mobilized and challenged. And certainly that's another thing that I personally think is a big difference between major centers and smaller hospitals, centers with, stoma nursing care over the weekend and other things which really, make ERAS truly meaningful. I thank you very much for all those comments. I've got one question to the panel. So the management of patients with fulminant toxic colitis that need salvage medical therapy is quite challenging, and particularly the people who are at highest risk of DVTs tend to be the ones that are actively bleeding. And so how do you approach a patient who is requiring transfusions? You're probably waiting to see if they will require a total colectomy, but they're not quite there yet. Do you anticoagulate? Do you think about a filter? Do you just cross your fingers? What does Baylor do?
I guess we can run the faculty that are present, but I'll start by saying if they're actively bleeding, I'll not anticoagulate, but do everything that you can otherwise with SCDs and ambulation.
Usually if they're actively bleeding, requiring transfusion, I think at that point the ship has sailed and is sailing towards the operating room. In my book, not immediately when they present to the hospital, but whatever approach you, steroids or whatever you are treating with, if they're bleeding requiring transfusion, I think the next step is surgery. And no, I don't use filters for those. Because once the colon is out and the rectum usually stops bleeding and you can start anticoagulation relatively quickly. You brought up a very good point that we debate almost on a daily basis when to start prophylaxis. We have some proponents of pre-op and others of post-op in our group. So this would be a case perhaps where I would start post-op. One of the very few cases where I would start post-op.
Thank you. Anyone else from the panel? Any opposing opinions? I think Dr. Fleshman has put his hand up.
So my belief is that if they're severely inflamed and while the colon is still in place, they're the highest risk individual that we have. The amount of bleeding that you get from prophylaxis is very low. It's also stoppable. And I agree with Katerina that SCDs would work nicely, but I would not hesitate to give someone Lovenox if they're also still in a hypercoagulable state. The first patient that I ever operated on with ulcerative colitis was a young woman who was in the hospital being treated for ulcerative colitis, severe, and eventually ended up with a colectomy, who had a superior sagittal sinus thrombosis. It was devastating. You cannot predict who that's going to be. And had she been on prophylaxis, she probably would not have developed that. And so I really feel like we need to think about that. I agree with Alessandro. If they're bleeding, they need to go to the OR. If they're severely inflamed and they have some rectal bleeding, I think we ought to be making sure that the hypercoagulable state is dealt with appropriately.
Thank you. Dr. Lee Schleider, I think, has his hand up as well.
I would think that if the bleeding is from their usual disease state and they're not actively significantly bleeding, I think the hypercoagulability still outweighs the risk of DVT prophylaxis, as Dr. Fleshman just said. And then realize even Scott Steele's database from Seattle or state of Washington, 90% of their patients with DVT or PE were on appropriate prophylaxis. So right now we can reduce the risk, but we haven't eliminated the risk. And I always remember the patient I had who had DVT and PE while at the same time developed bilateral adrenal gland hemorrhage. So he was hemorrhaged and had a Waterhouse-Friedrichsen syndrome and is now on long-term Florinef stuff, but he had a DVT and PE. So, you know, we can have clot and bleeding at the same time. So I think we really need to look in terms of prophylaxis, unless they're just actively bleeding, tachycardic, et cetera.
Thank you. It's really a challenging balance. I have one last question before we move on. And this is about a paper called Superior Mesenteric Vein Thrombosis After Colectomy for Inflammatory Bowel Disease. As the saying goes, the internet is forever. It's a Dr. Vicero's paper from, I think, 2003. But my question is perhaps a quick overview of the management of mesenteric thrombosis, or your personal sort of salient points of what we look for and when do we address this?
So, Vlad, I thought you were my friend, but you just gave Dr. Wells and Dr. Stringfield ammunition for calling me old, quoting a paper from 2003. And that abuse goes on a daily basis. But that paper came from the time I was a fellow at Mount Sinai. And going back to the point I was trying to make earlier is those patients were symptomatic and diagnosed with a CT scan. So I'm sure we missed a lot of those patients. So the story was you had abdominal pain and elevated white count. We started checking LFTs later, but maybe a little bit of fever, and you will get a CT scan. And the CT scan will show a mesenteric vein thrombosis. Mostly laparoscopic cases, more than the open cases. At the time, we were starting to be more laparoscopic back in the day. So, but we saw a difference at the time, and we speculated what the reason could have been. Increase intra-abdominal pressure, traction on the mesenteric vessels, all made up hypothesis. Really, there was no way to prove it one way or the other. And 100% of these patients did not had radiologic or clinical signs of bowel compromise. And I can't really explain that because I don't remember the exact number of patients, but it was not a negligible number. And again, other than abdominal pain, there was no mesenteric engorgement or diarrhea, or the stomach looked normal. Mostly were abdominal colectomies. And so we treated them with 3 to 6 months of anticoagulation. And at the time was Lovenox. We actually worked most of them up for any hypercoagulable state, and we didn't find any other than, again, they were acutely inflamed and sick and with inflammatory bowel disease. So 3 to 6 months of anticoagulation with Lovenox, and then we stopped. And also, the majority of them, of course, went on to have a pouch if they were ulcerative colitis patients, and we had no problem at the second operation, suggesting again that the pro-inflammatory state of the acute flare played a major role in the original presentation, more than the laparoscopic, the intra-abdominal pressure, because the pouches were also done laparoscopic.
Thank you. That's very interesting. In the interest of time, we're going to quickly move to the results of the poll. We did also feature a study from Johns Hopkins with Dr. Leeds being a first author about cost limitations of extended prophylaxis after surgery, but unfortunately we'll leave that one be. Now, the results of the poll show that most people would restart therapeutic anticoagulation on day 3. and everyone answered the question. So thank you very much for participating. I guess, again, because we're a bit limited for time, I'm not going to discuss the fourth study that we featured this month about sort of the risks of bleeding from therapeutic anticoagulation. I think it is interesting to note that in that study, hemorrhagic complications outnumbered thromboembolic about 1 to 3-fold. Maybe just a quick comment from the hosts. Do you have a routine of when do you restart? Is it really a gut feel? Is it a case-by-case basis? Katrina, what do you do?
I try only to check labs once or twice during their admissions. Everyone gets labs post-op day 1. If the hemoglobin is stable and there wasn't an undue concern for bleeding in the operating room, then they start anticoagulation. If they start anticoagulation, they get a second check the next day, and if it's stable, that's all good and well. If there's a decrease, then anticoagulation is held until there's stability.
Are you particular in terms of what they start with? Is it Lovenox? Is it orals?
I'll start with something reversible, or at least short onset, so a heparin drip, and then if they're eating, then they'll go back onto whatever their anticoagulant was.
Fantastic. Anyone else has any other views on this?
I was one of the others on the poll, and I usually start if the blood count is okay post-op, start at day 2 with therapeutic Lovenox, and then I'll switch them to their oral anticoagulant by the time of discharge, and I'll bridge the 2.
Thank you. I find that the anticoagulation personally biases me more than anything else that I sort of, any other decision that I have. And it really depends on how much bleeding I had in the previous patient I anticoagulated. Anyway, thank you for all these answers. Now, with no further ado, let's move on to the special guest segment. And today we are featuring Dr. Fichera. Just briefly, he obtained his medical degree in Rome, Italy, which I'm very jealous of from a geographical perspective. Following completion of residency in the University of Rome, he moved to America. He did his general surgical training through the University of Chicago, and then, as he briefly mentioned, fellowship at Mount Sinai. Dr. Fichera has many hats. He is the division chief of colon and rectal surgery at Baylor Health. He is the clinical professor of medical education at Texas A&M University. From a DC&R perspective, he is section editor of the didactic video collections, and this collection will form the focus of our discussion. And again, I'm very grateful to have his time. The first question I have to start off is, what is the didactic video collection, and how did you think of this, and how did it evolve?
So first of all, thank you for having me here as the special guest. It's kind of interesting, a special guest in my own house, but it's still a big honor to be here and to talk about the didactic video library. I cannot take 100% credit for this, because this is an idea that sort of bounced back and forth with Dr. Galandiuk and got modified and improved and became what it is now, and is still evolving, because we talk about what to do next more often than not. It started as an idea, a way to have garden variety basic operation that we do every day, illustrated in a very schematic fashion with a little introduction, so you can read and watch what the steps are, intended for junior faculty, general surgery resident, fellows in training, general surgeons out there that don't end up doing a lot of colorectal. I have to say that reviewing every single paper, every single video, I've learned a lot. There is a lot of different ways of doing simple things. We recently reviewed perirectal abscesses, pilonidal disease, to intracorporeal anastomosis. It doesn't matter. There is always something that is done in a way that is different from the way I was trained, or I do it, or I've seen it before. So I started with this very basic concept, and has evolved in a for me at least, and I'm sure others. I've seen name of people that that have contributed to the library, are attending this journal club. I'm sure they also have benefited quite a bit from it.
Thank you. So then my next question is, where do you see yourself taking the collection? And I'm a little bit biased myself, because later this year, we're going to have a DCR journal club where we'll try to integrate some of the pelvic floor videos and have some experts in the field comment on them in real time. I guess what's in store for the future next year, in 3 years? Do you have a cap of how many videos you are looking for?
So first of all, it's not what I am going to do with it, but rather what DCR and its editor-in-chief and the other editors as well, the other section editors and associate editors have all suggested and tried to make it better. So it's really a team effort. As you progress, you realize that just having 5 right hemicolectomy and 10 low anterior, it's not enough, right? I don't think there is going to be a cap. We're going to cap at 10, whatever, because as I said, there is always a different way of doing the same operation. So I don't see capping it. Now, the idea is to, once we have a critical mass, like we do for some of the pelvic floor, is to have a discussion reviewing those videos that are, by the way, peer-reviewed and result in a publication. So it's not just an academic exercise for the authors. They receive a paper in return, and the peer review is actually very constructive. So we have these selected, edited, cleaned videos that are available to everybody, but also we will put them together, try to show the different ways of doing things, discussing with experts in the field, and just looking at the number of people that are on this journal club. This is the way people like to receive information. I see names of junior faculty, people in training, general surgery resident, more experienced people. This applies to everybody. So I think the sky is the limit. I see Dr. Galante looks like she's thinking still already about the next step, but for now, the next step will be to bring them together and have a discussion with experts on the field to share, different ways of doing things.
Thank you. You probably in part already answered this following question, but I guess why would you recommend for surgeons to submit videos to this collection compared to other sites or YouTube or something like that? So
that's a great point. And we received initially this very question, right? You publishing on DCR is sometimes time consuming and difficult, and so we made it as easy as possible. And people that have reviewed for me know that if they don't submit the review or accept the paper, they get a text message or a call or an email. So they made it very easy. The instructions on the website are very clear. So it's very unusual to get a paper that is not good quality. It may not be ready for publication, but they're usually good quality. So why? Well, you do operate, you do or record some videos, and especially because we want garden variety operation, those are cases that shouldn't take a lot of effort to record. You get feedback, you get a publication. And those videos are available on the DCR YouTube channel. So it's a great way to show the world what you do and what you do well. So I don't see a downside to that.
Well, I've submitted my first video. Had a resident submit the first video just recently, so hopefully we're successful. But it was quite an enjoyable experience. My last question is about adaptation of new technologies and/or new techniques. I guess it appears that as further one gets away from the age of fellowship or writing a paper in 2003, the more challenging it is to adopt new things, because the learning curve seems or feels like there's more to lose. And so I guess from your experience, and maybe there's some overlap with the didactic video collection, how do you embrace new technology, and what are the steps of you going from a theoretical to a practical acceptance of a new technique?
So you're absolutely right. The more remote you get from training, the harder it is to accept new techniques and technology, because what you have been doing actually does work quite well. And you must have talked to Dr. Newton, who convinced me to do a laparoscopic operation that turned out to be great, but she had to sort of do some convincing. So she can test to that. I think there is a happy medium between the more seasoned people having a little bit of resistance and the more junior individuals that are a little bit more cavalier. There has to be a happy medium. I think nowadays, obviously, training, fellowship, learning from the masters is always the best way to go. But we have so many tools out there, so many different media available for us to learn new things. Other than the half-a-day course with industry, there are so many other ways, including video-based education. Either a didactic video library and other societies have similar situation. I think the difference with the didactic video library is the focus is the basics. And we start with the basics, and we have some very complex videos and advanced videos in the library, but that is the basis of our experience. But out there is a lot. I embrace personally new technology when I hear from somebody I trust and respect. That's really the number one factor that forces me to look at it and open my mind to new things. So and then the older you get, the longer it takes to learn new tricks. Like they say, teach an old dog new tricks. It's a true statement. Again, the fellows can attest to that for sure. Oh, and by the way, I just wanted to mention, I see Dr. Vojtovic. She's our third fellow. I want to mention her name as well, since she's an integral part of our group with Sommerholder and Dr. Newton.
Thank you very much. And I think as I told Dr. Wells, I had the pleasure of meeting the previous fellows last year at ASCARS, and they seem to be a great group. So I have no doubt that this group is also socially very appropriate, and therefore hopefully very employable. So thank you very much for your time and on all the answers. Now, our next meeting is going to be held in the Cleveland Clinic, and we're going to be focusing on hernias with Dr. Mike Rosen being the special guest. So thank you everyone for tuning in, and see you next month.
Yeah, and please submit to the didactic video library. It's very easy, very simple. Especially the recent fellows. I see some on the call. It's a great opportunity to get a publication.
Thank you, Dr. Bolchinski.
Yes, thank you, Dr. Bolshinsky. Thanks for having us.
Thank you. Bye.
Thank you, everyone.